Hey everyone, Dr. Steve here. You know it as well as I do, but most students need a B or better in A&P. But did you know that students are doing that all over the US using my Anatomy and Physiology Digital Suite as a low-cost alternative to expensive textbooks? Digital Suite delivers the key concepts of A&P with short, assignable tutor videos and a bulleted narrative study guide that not only explain the concepts of A&P, they show them happening. Combined with state-of-the-art dissection and physiology lab simulations and a vast question bank for quizzes, homework assignments, and exams, Digital Suite meets students where they are and gives them the tools to master the content. It's the perfect supplement to an OER textbook or just on its own. If you're an A&P instructor, contact your McGraw-Hill representative today and ask about Anatomy and Physiology Digital Suite. If you're a student, tell your instructor about it. There's a link to Digital Suite in the show notes of this episode. Get your B or better in A&P with A&P Digital Suite. Hey everyone, welcome to my podcast, Anatomy and Physiology Bit by Bit. I'm your host, Dr. Steve Sullivan, coming to you from Bucks County, Pennsylvania, where I've been teaching A&P since 2002. In today's episode, we're going to begin to talk about aging. This is going to be part one of a 2-episode coverage of aging. In the 75 previous episodes of this podcast, we've talked about all the workings of an adult human body. Then we got into pregnancy, embryonic development, and the neonatal period. So now we'll take the jump to what happens to our bodies during the passage of time, especially when a lot of time has passed. As we age from childhood to adolescence to adulthood, we grow and our bodies obtain their full functionality and maximum efficiency. But then, as we further age into adulthood, our organ systems begin to slowly degenerate. This process is called senescence. Senescence touches every organ system in our bodies. In this episode, we'll travel system by system, but keep one thread in mind. Aging is not a single event, nor is it a single pathway. It is a slow contraction of our physiological reserve, a narrowing of our body's margins for error. We have a reduced capacity to repair damage, compensate for stress, and resist disease. That shrinking reserve is why the same flu that requires a teenager to just lay low for a few days can stabilize an 80-year-old for 2 months. And why a brief hospitalization can echo across an older patient's organ systems long after they go home. First, let's talk about the current demographic landscape. A century ago, infectious diseases cut most lives short before the age of 65 because the first clinical use of antibiotics wasn't until 1941. Today, roughly 3/4 of deaths in the United States occur after age 65, and almost 15% of Americans are already in that age bracket right now. This demographic shift means the clinical conversation has moved from trauma and acute infections to chronic conditions whose roots intertwine with senescence. These include cardiovascular disease, cancer, stroke, diabetes, chronic lung disease, and the infectious complications that exploit our waning defenses. Pandemics are real good at revealing this pattern. The case fatality curves bend steeply with age, reminding us how our reserve declines. Yet aging doesn't arrive uniformly. And that's your first operational lesson. Physiological peak usually sits somewhere between the late teens and age 30. After that, curves slope downward, but with widely different gradients. Nerve conduction speed may fall by only 10 to 15% from 30 to 80 years old, while kidney functional units, the glomeruli, may be reduced by more than half. Some changes are invisible at rest, but roar into view under exercise. What looked like normal cardiac output on the couch reveals its limits on the treadmill. Some processes show signs of senescence early in life. For example, fatty streaks in the arteries begin to appear in childhood. Meanwhile, progesterone and estrogen levels hold steady for decades until a cliff-like drop-off during menopause. Nearly every trajectory is modulated by use. What does that mean? It means that tissues in demand tend to hold their ground longer, while a lack of use or disuse accelerates decline. It's a common theme. Move it or lose it. I've said it before on this podcast. I've brought up exercise many times. In fact, multiple guests, physicians and PhDs alike, have suggested exercise as one of their most vehement recommendations. So I know I'm a broken record with exercise and moving your body, but it is essential to optimal health. Okay, like I said, we're going to go system by system, and we'll start with the integumentary system, where aging is visible and consequential. If you want to review my episodes on the integumentary system, they are numbers 9 and 10. By the late 40s, most patients can point to their skin and hair as tangible evidence of the passage of time. Hair thins and grays as melanocyte activity falls off, and hair follicle cycling falters. Dead hair shafts aren't replaced as reliably as they once were, and sebaceous gland atrophy dries the skin and hair. Epidermal mitosis slows, dermal collagen is lost, and elastic fibers fray. The dermal-epidermal junction, once characterized by dermal papillae, flattens, loosening the Velcro-like grip that once stabilized the skin against shearing forces. You can see the difference between the skin of a child and a senior citizen when you pinch it between your fingers. Skin tightness and elasticity transitions to laxity and sagginess. Under the surface, blood vessels are fewer and they're more fragile. Leaks and visible clusters of small, damaged blood vessels known as telangiectasias, or spider veins, stain the noses and cheeks. Sensory acuity lessens as cutaneous nerve endings decline, so injuries are both more frequent and less noticed. When they do occur, they're slower to heal due to a decrease in vascular perfusion. We also have fewer resident immune cells and fibroblasts, and a reduced number of antigen-presenting dendritic cells, which results in wider wound edges and allow bacteria to flourish. Thermoregulation is compromised due to the atrophy of sweat glands, the loss of subcutaneous fat, and decreased ability to contract vascular smooth muscle. Heat waves and cold snaps reveal those deficits, especially for the poor and poorly housed. With less homeostatic capacity, environmental stressors can become medical emergencies. Then there is the great amplifier, and I know you've heard this a million times: ultraviolet radiation. UV rays from the sun. Photoaging accounts for the lion's share of the integumentary changes patients find troubling or dangerous. Wrinkles, blotchy discoloration, solar lentigines, which are the benign brown spots on the skin, actinic keratoses, which are rough, scaly patches of skin that are precancerous, and actual skin cancers. That leathery, outdoorsy face that may look rugged is actually a histologic map of damaged vessels, abnormal keratinocytes, and dense clumps of abnormal elastin. These are not merely cosmetic. They are risk markers for malignant cells. But here's the clinically crucial ripple effect. Reduced cutaneous vitamin D synthesis, compounded by less outdoor time and lower dairy intake, often due to acquired lactose intolerance, pushes older adults toward vitamin D deficiency. That deficiency drags calcium absorption down, and with it, bone mineralization, muscle strength, nerve signal transmission, and glandular function. Aged skin, therefore, tells a skeletal story, a neuromuscular story, and an endocrine story. Okay, let's get into the skeleton. Bone mass, bone matrix, and osteoporosis, which we call the quiet or silent thief. After about 30 years old, the seesaw starts to tip. Osteoclast resorption inching ahead of osteoblast deposition. The result is osteopenia, which may progress to osteoporosis when losses cross the threshold that puts skeletal integrity and independence at risk. Biological women lose approximately 8% of bone mass per decade after 40. Biological men about 3%. Bone loss in the alveolar processes of the mandible and maxilla hasten tooth loss, reshaping diet and nutrition. Now, osteopenia is just a loss of bone mass, but not all bone loss is osteoporosis. Normal aging brings a gradual decline in bone mass, but osteoporosis refers to when this loss reaches a pathological degree, associated with significant fracture risk. Bone mineral density is measured with something called a DEXA scan. DEXA is short for dual energy X-ray absorptiometry. The scanner uses two low-dose X-ray beams at different energy levels. The principle is that bone and soft tissue absorb X-rays differently depending on their density. So by comparing absorption at the two energies, the machine can subtract out soft tissue and calculate how much mineral, mainly calcium hydroxyapatite, is present in bone. DEXA scanning gives us two measurements. One is called the T-score, and the other is called the Z-score. The T-score compares the patient's BMD, which is bone mineral density, to that of a healthy young adult of the same biological sex. 1.0 or higher is normal. 1.0 to negative 2.5 is osteopenia, which means low bone mass. Negative 2.5 or lower is osteoporosis. Z-score compares the patient's bone mineral density to someone of the same sex and age. A very low Z-score suggests secondary osteoporosis due to another disease or perhaps a medication that causes bone loss. The World Health Organization uses this same DEXA scan. They rely on the T-score, the minus 2.5 or lower, and typically we're looking at the spine, hip, or wrist. And that's how the WHO defines osteoporosis. To appreciate why bones weaken in osteoporosis, you have to revisit bone remodeling, which I covered in episode 13 of this podcast. Bone is not a static tissue. It is living, dynamic, and constantly undergoing turnover. In osteoporosis, there is more resorption of bone than deposition in the remodeling process. A key physiological driver of this imbalance, especially in biological women, is estrogen deficiency. Estrogen normally suppresses osteoclast activity. With the loss of estrogen at menopause, osteoclast activity surges without estrogen there to put on the brakes. We classify osteoporosis as either primary or secondary, which I mentioned a little bit earlier. Primary means the osteoporosis isn't being caused by another disease process. Secondary means it is. There are two main subtypes to primary osteoporosis. Type 1, or postmenopausal osteoporosis, occurs in biological women after menopause due to estrogen deficiency. It preferentially affects trabecular bone, so vertebral compression fractures are common. Type 2, or senile osteoporosis, occurs in both biological men and biological women over the age of 70. Here, the issue is less about estrogen and more about age-related decline in osteoblastic activity. Also, it considers reduced calcium absorption and impaired vitamin D metabolism. Secondary osteoporosis arises from identifiable conditions. Endocrine diseases such as hyperthyroidism, hyperparathyroidism, and Cushing's syndrome, which is hypercortisol secretion, can accelerate bone loss. Chronic renal disease, chronic liver disease, and malabsorptive conditions such as celiac disease and Crohn's disease can all contribute to secondary osteoporosis. Certain medications are also notorious for decreasing bone mass. Long-term glucocorticoids, anticonvulsants, aromatase inhibitors, and gonadotropin-releasing hormone agonists are just a few. And don't forget lifestyle. Alcoholism, smoking, and physical inactivity all predispose a person to osteoporosis. We know from Wolff's Law that weight-bearing activity increases bone density. So the more active you are, the less at risk you are for a decrease in bone density. Osteoporosis is called a quiet thief because it causes no pain or symptoms until a fracture occurs. And the typical fractures are vertebral compression fractures. These can be painless or present with acute back pain, loss of height, and progressive kyphosis, the so-called dowager's hump. Hip fractures, these are catastrophic in older adults, often requiring surgery and associated with high morbidity and mortality. When they say hip fracture, they don't usually mean the hip joint. They usually see a hip fracture in the femoral neck. And then there's also distal radius fractures, which are common when patients fall onto an outstretched hand. In fact, there's a lot of wrist fractures that are referred to as Foosh fractures, F-O-O-S-H, which stands for fall on outstretched hand. Once a patient sustains one fragility fracture, their risk of more fractures increases dramatically. There are some ways to prevent osteoporosis. First-line management always includes lifestyle modifications. Patients should ensure adequate calcium and vitamin D intake. Remember, vitamin D is required for calcium absorption in the small intestine. Weight-bearing and resistance exercise helps stimulate bone remodeling. Quitting smoking, limiting alcohol, those things are essential. And for older adults, fall prevention strategies, improving home safety, vision correction, balance training, these are all critical. There are also medications that can be prescribed by a physician to counter the effects of osteoporosis and increase or maintain bone density. Not only does bone density decline with age, but the bones become more brittle as the cells synthesize less collagen. Fractures occur more easily and heal more slowly because the collagen is what gives the bone some flexibility so it can bend a little bit without breaking. Take away that flexibility and bones are more like a dry stick than a living branch. A fracture can impose a long period of immobility, which makes a person more vulnerable to pneumonia and other life-threatening infectious diseases. As they age, people also notice more stiffness and pain in the synovial joints. And degenerative joint disease affects the lifestyle of 85% of people over 75. Synovial fluid is less abundant and the articular cartilage is thinner or even absent. Exposed bone surfaces rub up against each other and cause friction, pain, and reduced mobility. We've often heard this called osteoarthritis. It is the most common joint disease of older people and one of the most common causes of physical disability. The name osteoarthritis is a little misleading because it's not really an inflammatory arthritis. There are arthritides caused by inflammation like rheumatoid and psoriatic arthritis. But osteoarthritis is a degeneration of the articular cartilage that lines the joint surfaces, so a more accurate name is degenerative joint disease. Even breathing becomes more difficult and tiring in old age because expansion of the thorax is restricted by calcification of the sternocostal joints. Remember, these are the joints between the sternum and the costal cartilage that continues from the rib to the sternum. Remember, that's hyaline cartilage. Degeneration of the intervertebral discs causes back pain and stiffness, but herniated discs are less common in old age than in youth because the discs become more fibrous and stronger with less nucleus pulposus in the middle. Okay, let's talk about muscles. A loss of muscle is called sarcopenia. By the time we reach our 70s, half of youthful strength and endurance may be gone. Cross-sectional imaging of the thigh shows us this shift. Contractile tissue recedes and is infiltrated by fat. The diameter of myofibers shrinks, especially among fast-twitch fibers that once powered quick reactions and fine coordination. Tasks like simply rising from a chair, lifting a grocery bag, buttoning a shirt, now require multiple motor units firing near their maximum capacity. Inside the muscle cells, we also see distinct changes. Fewer myofibrils per myofiber, disrupted sarcomere alignment, meaning the thick and thin fibers are not lined up the way they used to be, smaller mitochondria that produce less ATP, a decrease in ATP stores, reduced glycogen, and reduced myoglobin. Fibrosis and fat accumulation stiffen the tissue and decrease microcirculatory blood flow. And we are slower to repair damaged tissues, and scar tissue formation increases. Related to the muscles is the senescence of the nervous system because their motor innervation gets affected. There are fewer anterior horn motor neurons in the spinal cord's gray matter. There's a loss of nerve innervation, and that all causes myofibers to atrophy. We also have reduced acetylcholine output, which means a decrease in myofiber stimulus. And less efficient neuromuscular transmission makes it take longer for nerve signals to get from the central nervous system to the muscles. The sympathetic nervous system's more sluggish vasomotor adjustments mean exercising muscles receive perfusion late and lose it early, meaning fatigue arrives sooner and lingers longer. The clinical arc is usually a spiral. Weakness leads to reduced activity, leads to faster loss, leads to falls, leads to fractures, leads to immobility, leads to infection and thromboembolism risk. That's blood clots that travel. Resistance training can break this spiral at almost any age. Even people in their 90s substantially increase strength with modest, regular isometric exercise. And that's not a miracle, that's biology. Hypertrophy of remaining fibers, improved motor unit recruitment, and neuromuscular efficiency. All right, how about the brain and the nerves? After 40, brain mass declines on average about 5% per decade, and that pace increases later in life. But remember, the brain doesn't age everywhere, and it also doesn't age equally. The prefrontal cortex and hippocampus are hit the hardest. Executive functioning, judgment, planning, explicit memory formation, the familiar complaints, slower recall of recent events, easier access to long ago stories. They fit that map. Microscopically, aged neurons show less rough endoplasmic reticulum and Golgi complexes, implying a lower capacity to synthesize proteins and get them to their destinations. Lipofuscin pigments accumulate. Lipofuscin is an age-related wear and tear pigment found in cells, particularly neurons, and retinal pigment epithelial cells. They are formed from the accumulation of undigested cellular waste. It results from oxidative damage, which is an imbalance of free radicals and antioxidants, and a decrease in lysosome function. The pigments inside lysosomes are producing reactive oxygen species when exposed to light, which contributes to cell dysfunction and age-related disease. For more on free radicals and reactive oxygen species, listen to episode 57 of this podcast, which covers our immune system's second line of defense. We also see clusters of neurofibrillary tangles. Neurofibrillary tangles, or NFTs, are clusters of hyperphosphorylated tau protein that aggregates inside neurons. Their clustering is not random but follows specific patterns in the brain, particularly within neural networks susceptible to degeneration in conditions like Alzheimer's disease. In some brains, amyloid plaques appear in the extracellular spaces. Amyloid plaques are dense, extracellular protein deposits also found primarily in the brains of individuals with Alzheimer's disease. They consist mainly of the amyloid beta protein, which, when misfolded, aggregates into harmful clumps that can disrupt communication between nerve cells. Our myelin sheaths degenerate unevenly, slowing nerve conduction velocity and desynchronizing network timing. Neurotransmission becomes less potent due to fewer neurotransmitter molecules being released, fewer postsynaptic receptors, and the buffers that astrocytes provide get leaky, allowing neurotransmitter drift out of the synaptic cleft. Clinically, the autonomic nervous system senescence is prominent. Loss of adrenergic receptors for epinephrine and norepinephrine and effector responsiveness blunts our baroreflexes. These are the reflexes associated with blood pressure. Orthostatic hypotension becomes common. Orthostatic hypotension means when you get up from a seated or reclined position, your blood pressure doesn't respond and increase to accommodate gravity and get blood to your brain quickly enough. And then when you combine this with slowed righting reflexes keeping your head upright and fragile bones that can break if you fall, this could be a really catastrophic situation for an older person. The typical cascade of stand, sway, fall, fracture, and pneumonia can unravel in seconds and echo for months. Now, not all cognitive domains decline. Vocabulary and crystallized knowledge may hold or even grow. Cognitive reserve built by education, mentally stimulating work, social engagement, seems to buffer the expression of pathology, delaying clinical thresholds. That too is actionable medicine. We can't rewrite genes, but we can encourage lifestyles that maximize reserve. Let's talk about sensations and the sense organs. Back in episode 30, I covered vision. We lose our capacity for accommodation early as the lenses lose their elasticity and can't recoil back to their fully round shape when we try to focus on things that are close up. This is called presbyopia, and it's why people start needing reading glasses after about age 40 or so. Remember, accommodation is the reflex that contracts our ciliary muscles surrounding our lens and allows our lens to recoil back to its thick, round shape. That way it can maximize the refraction of light that's already come in through the cornea so that it can focus it right on the central fovea, which is the area of our retina that has the highest concentration of photoreceptors. Our visual acuity also declines as objects get blurrier. Cataracts gather on the lenses and make the world look cloudy and yellow. Corneas also get cloudy, but it's a little more subtle than the lenses. The vitreous and lens transmit less light, the baseline constriction of pupils is higher, and the retina itself loses photoreceptors. By age 60, the same scene is delivered to the retina at a fraction of the photonic flux it enjoyed at 20. Dark adaptation slows as photopigment cycles lag. Aqueous humor outflow may be impeded by microstructural changes, so the fluid inside your eye doesn't leave as quickly as it used to, and that increases the intraocular pressure, giving us a glaucoma risk. The functional consequences: trouble reading, driving, navigating dim spaces. They're not merely bothersome, they're dangerous because they amplify fall risk and shrink our social worlds because it becomes harder to leave home. Hearing follows a similar arc. The tympanic membrane stiffens, the synovial joints between the auditory ossicles don't move the way they used to, and the cochlea loses hair cells and afferent nerve fibers. High frequencies fade first, but the range of human conversation is also affected. Background noise becomes a hindrance to hearing the person you're actually talking to. And also, vestibular hair cells and their neural partners dwindle, resulting in dizziness and trouble with balance. Taste and smell become less sensitive as the concentration of gustatory and olfactory receptors declines. So that means food becomes less compelling, and we don't have the appetite we used to have. Not because we don't need the nourishment, but because we're not as attracted to food anymore. Which means malnutrition often slips through the narrow doors that this leaves open. Okay, finally for this episode, let's talk about the endocrine system. Compared to other systems, hormone secretions continue at a pretty regular pace. However, their target tissues become less sensitive to them. Two exceptions are front and center clinically: reproductive hormones and metabolic hormones. Gonadal steroids like progesterone, estrogen, and testosterone shift sharply. Menopause compresses the change in biological females, and biological males experience a decline in testosterone secretion, sperm count, semen volume, and libido. Combined with vascular disease, medications commonly prescribed to older people, and mood, these all contribute to erectile dysfunction. Growth hormone and thyroid hormone decline gradually after adolescence. The pineal gland progressively calcifies, reducing melatonin, contributing to circadian disturbances and insomnia, a difficulty sleeping. Insulin resistance also tends to climb, propelled by greater adiposity and lower muscle mass. Said another way, an increase in body fat and a decrease in lean body mass. Because muscle is a major glucose user, sarcopenia increases our post-meal glucose levels and keeps it elevated longer. Meanwhile, pituitary sensitivity to negative feedback can wane, and stress responses don't fade away as quickly as they used to. Translate that clinically: after a stressor, like illness or surgery, older adults take longer to reestablish their baseline. Okay, we're going to cut it right there for part 1 of Aging and Senescence. I appreciate you listening. I hope this helps. It's really interesting stuff. I know it's a lot of things to think about, and also it could be a little depressing when you think about it. We're all looking at this coming someday. So hopefully it's not bothering you. Think about it clinically. Think about it from an anatomy and physiology standpoint. I think that's your best bet. Well, once again, thank you for listening. I really appreciate it. If you've got a minute, please take the time to rate and review the podcast on whatever platform you're using. I can't tell you how much it helps to really get the show out there for people. And if you have a question, feel free to give me an email, minus55media@gmail.com. Ask me your question, and I'll try to answer it on the show. Once again, I hope you're getting your B or better in A&P. Good luck on your next exam, and I'll talk to you next time. Anatomy and Physiology Bit by Bit is a production of Minus 55 Media and is hosted by the Believe Network. Please take the time to rate my show and leave a review. You can also check out the content I post on Instagram and YouTube as @StudentHelp4AP. That's the number 4 AP. Special thanks to my family, Bucks County Community College, and McGraw-Hill Education, where your instructor can find Anatomy and Physiology Digital Suite, my low-cost tutor video-based digital learning solution for anatomy and physiology currently being used at several colleges and universities. If your instructor isn't using Digital Suite, let them know about it. The link is in the show notes.
This is the story of the one. As a custodial supervisor at a high school, he knows that during cold and flu season, germs spread fast. It's why he partners with Grainger to stay fully stocked on the products and supplies he needs, from tissues to disinfectants to floor scrubbers. All so that he can help students, staff, and teachers stay healthy and focused. Call 1-800-GRAINGER, click Grainger.com, or just stop by. Grainger, for the ones who get it done.